afternoon, everyone. I hope everyone has managed to stay warm in some unseasonably cold weather here in Washington, D.C., and had some coffee to help to keep from slipping into that inevitable post-lunch conference food coma. Thanks to my friends at ParXL for letting me go first. Chuck, you'll have to probably be a lot more animated than I am to keep everybody awake in the sessions upcoming. My name is Nathan White with inVentiv Health, one of the nation's leaders in healthcare product development and commercialization. If you're not familiar with us, I invite you to stop by our booth in the back of the foyer and pick up some information. I've certainly enjoyed the discussion thus far today and look forward to switching tracks in this panel and the upcoming panels for a little while to discuss the reimbursement and coverage side of the summit. Thanks to Elise for her great comments. She certainly made it clear that critical observation is necessary to arrive at good science-based evidence. She also outlined some of the various methods in which observational data can be collected and analyzed. And it was also very important to me what a tremendously important role health information technology will play in this movement towards making real-world observation a more integral part of the coverage decision-making process. Also very interesting to note how CMS and ARC are already collaborating, principally how CMS has posed these specific questions to ARC that will allow them to make more informed coverage decisions. So as the pharmaceutical industry prepares to embark on what will be one of the most challenging decades in U.S. healthcare history, I want to note some important questions. How will healthcare reform shape the future of the industry? How will we attack the challenge of proving value to payers? How will we reshape our business models to be more streamlined and efficient? And ultimately, what does this perfect storm look like, and how do we prepare to successfully weather it? Clearly, increased premiums and cost sharing have become not only a burden to patients and providers, but also to industry, as we're expected to shoulder much more of the cost burden through free drug and copay assistance programs. And certainly through the rest of the afternoon, you'll hear a lot more around comparative effectiveness research, and I'll talk just briefly on that today. Also, with the expansion of coverage to millions of uninsured through new Medicaid rules and the creation of low-cost health plans offered through health insurance exchanges, we'll see an entirely new type of patient evolve, a grossly underinsured patient looking to who for answers to the folks in this room. And we've heard today how the industry faces tremendous pressure to demonstrate safety and efficacy to FDA. But for the purposes of this discussion, however, we'll focus on the pressure on industry to demonstrate value to payers and the challenges associated with transforming some existing programs that already might be in existence that still have some value in today's commercial environment in light of this increased need for better evidence. So this brings us briefly to look at the Patient Protection and Affordable Care Act of 2010, also known as the Affordable Care Act or Healthcare Reform. Over 2,400 pages of law that, frankly, no one has a clear pathway or answer to how every part will be implemented with some degree of guaranteed success. And with the new Congress stepping into Washington next year, the uncertainties of how the Affordable Care Act will be implemented continue to mount. We've seen the quick evolution of comparative effectiveness research, both in terms of the definitions, or in some cases the lack thereof, in both the Recovery Act and the Affordable Care Act, as well as the creation and dissolution of the Federal Coordinating Council for CER, and the recent creation and appointments to the governing board of the Patient-Centered Outcomes Research Institute. Additionally, how states will afford the required expansion of Medicaid coverage is really anyone's guess. Be interested to see if anybody has some opinions on that later on. Ultimately, the Affordable Care Act aims to increase the quality of care while reducing the overall spend on health care. A simple focus in concept, but absolutely monumental in reality. A huge responsibility of making this focus a reality rests in the hands of the private sector. The federal government can certainly push forward new rules to direct the private sector, but it's up to us to collaborate with federal agencies, with federal corporations such as ARC, CMS, and NIH to make healthcare reform a success. So what do we consider to be one of the most challenging and least defined components of what we call the value equation? We believe it is the economic component. specifically comparative and cost effectiveness. And aside from the methodological concerns, lack of quality instruments, and associated risks with comparative effectiveness research, the bigger question is whose responsibility is it to demonstrate value, specifically in the area of pharmaceutical products? And with so many players involved, including the Agency for Healthcare Research and Quality, the National Institutes of Health, Patient-Centered Outcomes Research Institute, Centers for Medicare and Medicaid Services, private payers, patients, providers, and definitely industry. Who's responsible for providing, collecting, analyzing, and utilizing this valuable data to make more informed decisions about our nation's healthcare and the associated costs? And I believe it is everyone's responsibility in this room. But specifically, let's focus on the patient for a moment. The patient is perhaps the most important player in this entire paradigm and probably the most often ignored or forgotten. The area of patient-reported outcomes has certainly received a lot of attention as of late, specifically because of its important role in CDR studies. The patient can teach us, if executed in a thoughtful and science-based manner, many things we can't learn within the confines of the artificial environment of a randomized clinical trial. These self-reports by a patient are often in the form of a questionnaire administered by the patient or perhaps a healthcare professional, sometimes over the phone or web, and sometimes in person. And specific questionnaires are disease-specific, while others help to assess the overall general health state of the patient, which can be used in conjunction with analysis of both pharmacy and medical claims to create a holistic picture of the comparative quality of health to the economic burden to a patient and a payer. But ultimately, patient-reported outcomes attempts to assess impairments to the patient's health and well-being, as well as their overall quality of life. There we go. Sorry, this is getting a little bit of trouble. All right. So there are many patient-reported outcomes tools and instruments available, with most being disease-specific. The most widely used general pro instruments are the SF36 and the EQ5D. I'll be interested later in the panel discussion to hear from Elise or other audience members with health economics backgrounds as to their opinions on both the benefits of the currently available tools versus their limitations. There are a couple federally funded initiatives in pro that I want to mention. You heard earlier from Elise's presentation about the DECIDE Network, which is a ARC-sponsored group of principal investigators who are looking at outcomes, effectiveness, safety, and usefulness of medical treatments. Additionally, the NIH-funded PROMISE initiative is developing new patient-reported outcomes tools and will certainly be an entity to watch for new and exciting research in the patient-reported outcomes space. So let's take a step back for a moment and take a look at today's environment in the reimbursement world. Currently, industry has various segmented and focused groups, such as reimbursement, managed markets, government affairs, working together, and sometimes not working together, with brand stakeholders, all of which are having concurrent dialogues with CMS, with FDA, with private payers, sometimes with little to no sharing of information amongst the stakeholder groups. And oftentimes, reimbursement and managed market strategies are created in silos that don't take into account all of the commercial activities and programs and platforms operating across an organization. Certainly, we've seen regulatory organizations create REMS programs in a vacuum without input or collaboration with other internal stakeholder groups that create programs that touch those very same patients. So a few questions linger in my mind. What data is being collected across this entire continuum? What data can be collected tomorrow that isn't being collected today? What information will be valuable to payers tomorrow that we can begin to collect today? And how can we increase the overall value of our commercial programs to prepare ourselves for this movement towards real-world evidence? I'm going to talk for the next few minutes about 3 different types of programs and platforms currently used in the commercial and regulatory biopharmaceutical worlds that deserve some thought to how they could be transformed into more effective platforms and vehicles to that end goal of developing better evidence. The first and most obvious is the registry, and I won't spend too much time on this since Elise covered this in pretty fine detail, which is